Greetings. Welcome to day 3, the final day of the 11th Annual Symposium on Global Cancer Research. Thank you to those who joined us the past 2 days. If you haven't met me yet, my name is Mishka Kolisira from the Center for Global Health of the U.S. National Cancer Institute. On behalf of the ASGCR Steering Committee, it's my pleasure to welcome you today. Before we begin today's proceedings, just please be reminded of a few things. So the symposium is being recorded and will be made available after the event. We will ask attendees to please remain muted throughout the event today. If you do experience technical difficulties with audio or video, you can send a message in the chat to AV support and Des McNeil can assist you. And you are welcome to use the chat for questions and comments. And as you'll see in our session today, there will be other ways to be very interactively involved in today's event. Importantly, please also note that for the first time for ASGCR, we're offering simultaneous translation in French and in Spanish and English. So please select the interpretation globe at the bottom of your Zoom screen and select one of the 3 languages, English, French, or Spanish, and please make sure you select one of those 3 languages. You are also welcome to join us on Twitter and use the hashtag ASGCR23. For those of you who received the email this morning, you may have noticed that a bit of a change in the plan in terms of connecting between sessions today. So we did, for those who were here yesterday, we had some unanticipated technical difficulties navigating from yesterday's poster session on the Gather platform back to the Zoom session. And I really want to thank you all for your understanding and patience. Again, we do have a recording of the full session, including the oral abstract session, which will be available after the event. So for today, what we're going to do is we're going to close the Zoom link during the poster session on Gather, and then we will reopen the Zoom for the closing session. We will give more information about this at the start of the poster session. It's now my pleasure to introduce another of our ASGCR Steering Committee members, Dr. Eduardo Kazap. He's well known to many here, and he is the founding president of the Latin American Caribbean Society of Medical Oncology, the editor-in-chief of eCancer Medical Science, past president of the Union for International Cancer Control, amongst many other achievements. Dr. Kazap will be giving today's opening remarks. Dr. Kazap, over to you.
Thank you very much, Mishka. Good morning, good afternoon, good evening, dear colleagues. Welcome to the 3rd day of our meeting. I am the president of SLACOM, and I am also co-chair of the RINC-SLACOM partnership. That is a collaboration that is very active in the Latin American region for better cancer control. We are proud to partner with NCI-US and other sister organizations in this annual symposium on global cancer research entitled Closing the Research to Implementation Gap. So I would like to share with you my definition or concept ideas about these important words that we use, and I would like to really make some comments on the topic. Research. It is critical to understand that we are not only speaking about basic or clinical research. We need to really understand that many underserved countries and regions do need different types of research. We need urgently to have more epidemiological research, health systems research, and of course, one area of the research that applies exactly to the needs and urgencies of underserved countries of our global community. This is implementation research. I will talk a little bit later, but implementation research is now a critical tool to really make happen things that are only in documents, but we need to be applied to the populations. Of course, that we also need social research, to consider cultural aspects, and not lastly, economic aspect of cancer care. Today, one of the many unsolved problems in many countries and regions is related to economic situations. But we need to also analyze the concept of there is no money for cancer, or that cancer is very expensive. That is not totally true. The problem is the bad allocation of the existing resources. In many countries of the Latin American region, the cost of the funding for cancer care is close to 8, 7, 9 points of the GDP of the country, 10%, close to 10% of the income of the country. That is the case of Brazil, Argentina, Mexico. The problem is that healthcare systems are fragmented or are not efficient. So we need to really look at the problem of lack of resources, or the problem of maluse or not efficient use of resources. And why we need those different types of research? Because this information is vital to have data that will allow the development of strategic and efficient and affordable national cancer plans. It is impossible to develop national cancer control planning without enough data. Okay, let's now talk a little bit about implementation. If we have an helicopter vision of the world, we have an excess of norms, recommendations, programs, plans, guidelines. The problem is that many of those documents are only paper in the desk of many government officials or healthcare systems providers. We need to make real actions at the country level in order to improve cancer control and diminish cancer incidence. What about the causes of inaction? Lack of funding in some circumstances, or funding are not really well allocated to cancer, and in many health ministers' budget, the money for cancer is diverted to other needs of the government. Also, political situations. Something that is very common, not only in Latin America, is that when we have a new government, all the new official thinks that it is important to start from scratch again. And we lack of continuity, and we lack of real strategic plans, long-term strategic plans. You can see this particular situation, for example, in Peru, with 4 or 5 presidents in the last 5 years. And each president has a different team, a different minister of health, with different concept of healthcare and cancer. In addition to this, during the pandemic, many cancer plans were really not budgeted properly. And today we have the situation that many advances in cancer care in different countries of the world are now in a worse situation than before the pandemic. Cancer is not so frequent now in the political agendas. Cancer is not so well positioned in the urgencies of and priorities of the government. We need a strong movement to again put cancer in the global agendas and in the agendas of each individual country. In concrete, the problem about implementation is basically the failure to achieve an adequate implementation of actions. As an example of this, for example, clinical cancer guidelines that are very common in the world, NCCN guidelines, ASCO guidelines, etc. Do you know how many doctors in the US apply the guidelines? Less than 30%. The majority of patients in the US are not treated according to guidelines, but in many cases, not because of the doctor's decision, because of the system limitations, and that is much more frequent in our underserved countries, not only in Latin America. Another word that I think is crucial to understand for all of the people interested in cancer control is the word of global. What is truly global? Global does not mean in health to have a quick connection with another person in another part of the world. Global is mainly, as we understand the concept, that science must be global or universal. But today, cancer research is not really following the concept of universal. Because why? Because many of the studies start in developed countries. The needs of in development countries is not frequently taken into consideration. Usually, research investigators in many countries of the world are not developing their own independent protocols. They are providing patients to other studies, usually international, from Europe or US or Canada, usually. We need to have truly global studies to answer questions that are relevant to the patients and the doctors that are living in the real global community. For example, I am a 75-year-old man. So suppose that I have a lung cancer. Okay, so I go to my doctor and my doctor says, okay, your cancer is not surgically treated, you need chemotherapy or immunotherapy. Okay, well, and which is your recommendation? Well, this drug with this drug is the recommended drug. Why? Because this is based in evidence. Okay, which evidence? The evidence of a study with 2,000 patients from the US, an international study with 200 sites, and each site providing 5 patients and 2 or 3 sites providing hundreds. A study, in that study, how many patients of over 70 years old are included in the study? No, because the criteria for exclusion are 65. So the evidence for me, a man in Argentina, 75-year-old, means nothing. We need to develop real global cancer research in the countries that have a population with a particular needs, a genetic composition of the population that must be molecular or genetic differently to other populations of the world. One of our projects now at RINC-SLACOM is to map the resources in Latin America, in all countries in Latin America, for genetic and molecular studies, and see if there is a strong possibility to develop studies to really understand the genetic map of our populations. And finally, let's talk briefly about partnerships and collaboration. Global health problems are impossible to solve with an individualistic vision. Even the richest countries are unable to solve alone the complexity of global cancer research. It is necessary to develop strategic and well-planned partnerships and collaboration like this one to have practical and possible solutions. We need also to consider difficult topics as equity, minorities, migrants, and economic difference between many others. Well, I hope that you will enjoy a nice information and education day and the interaction. Our next session, the chair is Aruna Chandran, and the topic of this discussion will be collective action through the Global Alliance for Chronic Diseases, Networks, and Implementation Projects. Thank you very much. Aruna, you have the floor.
Thank you so much, Dr. Kasab. Very warm welcome to everyone. My name is Aruna Chandran. I am a public health officer at the International Agency for Research on Cancer. And today's scientific session is entitled Connecting for Cancer Control, Collective Action Through the GACD Network of Implementation Projects. And really the aim of this session is to explore the why and the how of collective action across the diverse groups to close the research to implementation gap in global cancer control and actually achieve impact. We will draw upon our experiences from the different GACD implementation projects from over 30 countries. Now, is the whole greater than sum of its parts? We will find out in today's session. And without further ado, I would like to invite all our speakers for today's session to briefly introduce themselves, perhaps starting with Lana, followed by Ishu, John Black, and last but not the least, Izzy. Over to you, Lana.
Miigwech. Bonjour everyone. Waskani Gijiko Kindigo, Jau Kanoji Nadodam, Apoganestin Nadunjaba, Kamanist Kwa Inda, Lana Ray Nadijnakas. My name is Lana Ray, and I just opened with my traditional Anishinaabe opening, which is customary. I'm an associate professor in the Indigenous Studies Department at Lakehead University, located in Northwestern Ontario. Nice to see everyone today.
Thank you, Lana. Over to you, Ishu.
Thanks, Aruna. Hi, everyone. I am Ishu Kataria. I work as a senior public health researcher with the Center for Global Non-Communicable Diseases at RTI International. I'm based in New Delhi in India. And the GACD project that I am a part of is focusing on improving access to cancer care in India. Thank you, Aruna.
Thanks, Ishu. Over to you, John Black.
Hi, everyone. Good morning, good afternoon, good evening. My name is John Black Kawuche. I am a medical doctor and a researcher in digital health. I work as a medical doctor at the Uganda Cancer Institute, and I'm also a postdoctoral researcher at the Stockholm University. I'm involved in the GACD project called Preventive, or that's the acronym, and it's about innovative ways of screening and preventing cervical cancer in Uganda, India, Bangladesh, and Slovakia. I think we can discuss more about that, but pleasure to be here.
Thanks, John Black. Over to you, Izzy.
Hi, everyone. I'm Izzy Banderek, and I am the Research Capacity Manager at the Global Alliance for Chronic Diseases at GACD. And I have the pleasure with working with all of these people you see on screen through the GACD Research Network.
Thank you, Izzy, and thank you, everyone, for your kind introduction. I think we shall get started with the session. We start off with Alana's presentation today on setting the scene for collective action. In this first presentation, Lana will be setting the stage. She'll be exploring the nurturance of local and global interrelationships as a strategy to support research to action and explore the questions: what are the benefits, practical limitations, and considerations of independent and collective action? So over to you, Lana, for your presentation.
Miigwech. So I think to start something a little bit interactive, if we could flip to the next slide, we have a Wordle for everyone, or a word cloud. So the question today is, do you know any other word that has a similar meaning to cancer? So we invite everyone to go to the internet address listed here and use the code to access the word cloud. So we'll just take a couple of minutes to do that. And maybe if you don't have another word, then you could just respond with cancer as well. Okay, seeing a couple: malignancy, carcinoma, tumor, mass. Yeah, a few more. Getting a little bit about potentially maybe some of the experience around cancer. And looks like tumor and malignancy are still the top answers. Okay, we'll give it just a couple more seconds for people to enter their responses. Okay, and so as it continues to form, I think something that I'm noticing when I look at the Wordle is a lot of the words that are coming up here are different words for cancer, but are still following within the same knowledge system. So we're still seeing a lot of biomedical terms to really think about and describe cancer. I'm also seeing in here some words that describe relationships or are more so focused on the experience of cancer. And I know, looking at death, which was a big one that was coming up, the work that I do, I work in Indigenous context within Canada, and you know, many issues in terms of access to care, both geographically as well as due to racism, discrimination. We have late stage diagnoses for Indigenous peoples in Canada. So those terms of cancer and death are very closely equated. And when that diagnosis comes, that's often what people think, that it is for sure a death sentence. And then it impacts, right, the way treatment rolls out if treatment is available. So miigwech, thank you everyone for participating. And kind of the purpose of that exercise was really continuing the train of thought that Dr. Kasab had mentioned, of having to think about maybe what our underlying assumptions are. So wanted to kind of be disruptive even at the core, and thinking about cancer, and even seeing that there's some shared similarities, but also there could be nuanced and maybe some non-nuanced differences when even thinking about what cancer means, what's important when we talk about cancer, and even the etiology of cancer. So I know in the research that I do around cancer prevention and care, and I work with traditional healers. So I've heard multiple terms that talk about cancer, and although there's similarities, there's also differences. So that very much impacts the way that we actually go about just asking if people could please mute themselves if they haven't muted yet, miigwech. So that could definitely impact the way that we go about the research process and the success of implementation of the research. So when we're thinking about approaching collaboration as well, we can't make assumptions that we share the same underlying assumptions. So miigwech everyone to your participation. So I think we could move on to the next slide now, please. So just to talk a little bit about the relationship between the local as well as the global, and traditionally, when we've talked about the global, or even some early iterations of talking about the global, the combination of the global and the local, there was an underlying assumption that was present there. And it was the idea that dominant modes of knowing and being very much underpinned when we're thinking about the global. So we have to work to critically reflect on that, as well as to deconstruct that. Because if we work within that false assumption that we are working in a global, but we're really just privileging dominant norms and ways of knowing and being, often when it comes to then working with community, what we have is a situation where it's more so window dressing. And then in terms of implementation, it may not be the most effective. So later iterations, more current iterations of thinking about the global really consider us to think about different hubs of locals coming together. So within that context, each local still maintains their own agency, still works within their worldviews, and works together in a very respectful space for meaningful collaboration. And so that's some of what you'll hear about in regards to the hub model that's really exists within GACD, where we have these different projects, but we come together. We just had an annual scientific meeting, and it was a really great opportunity to still be grounded within the local, but share within that global setting. And often when we're thinking about the global, when the underlying assumption is that we're operating from dominant norms, the focus always tends to be then in relation to those dominant norms. So the global, and again, we heard this from our opening remarks, often focuses on, for example, a partnership maybe between a low-income country and then a Western country. So also thinking about how can we foster those collaborations and relationships also between low and middle income countries too. So how do we actually employ a global framework that is very respectful for the interrelated and interconnected local states? So I've just included a few main points here in this bottom point. So firstly, the need for deep understanding, and that just goes back to our opening exercise of really being disruptive and challenging even some of those fundamental assumptions about what is research, what is implementation, even what is cancer, you know, what's needed for cancer treatment. Speaking again, going back to my context, there's an emergent body of literature that is beginning more and more to talk about actually colonialism being the key risk factor for cancer as well as other chronic diseases for Indigenous peoples within Canada. So also the need to challenge power dynamics. So thinking about their structures and systems and how those play out and work to reinforce current dominant norms, as well as accountability to the local. So what does that look like? There's a wonderful scholar by the name of Lana James, and something that she talks about predominantly in the context of Black people is often, you know, are involved in terms of the research, but due to issues of access and discrimination and racism and many other things, don't actually reap the same benefits in terms of the technologies that are coming out. And similar things happen within Indigenous context too. So next slide, please. So just digging a little bit deeper into where we can begin. I guess we really aren't beginning from scratch. So these documents may look familiar to some people. I just pulled a couple. So there has been some policy statements that have come out that really talk about, from a cancer specific lens, how can we go about cancer research and implementation in ways that address issues of equity and decolonization, and diversity and inclusion. So we see here there's a policy statement from the American Society of Clinical Oncology, and then there's a position statement here as well. So I've just pulled out from these 3 documents some of the key messaging that are present in all. So firstly is purposely applying an equity lens across the span of a funding opportunity. So even at our annual scientific meeting for GACD, we started to raise questions and have conversations about what does that look like in terms of who's actually in a leadership role when there's grants related to Indigenous or racialized populations. And what does that current funding structure look like? Also ensuring that continues beyond the funding opportunity into the research as well. And maybe just one last point on the funding opportunity. You know, I was so pleased when I had seen the call because there's so little research surrounding traditional healing and often research related to chronic disease and cancer, as was mentioned in the opening remarks, works within the biomedical model. And that is most definitely needed, but there's also many other components to create an integrated care model and model to hopefully eliminate cancer moving forward. So going back to thinking about applying an equity lens across the span of the research. So just drawing from the project I'm involved with, which is the CUGH Nanandawegamig Minobamadzawin Traditional Healing for Cancer Prevention project. That project actually came from community. When we talked about cancer prevention, and now it's also included a component around cancer treatment, but that's what the community said that they wanted. We want a way to access our traditional modes of health and healing more. So that's where we focused. So all the way from developing the question, developing the methodology. So I meet monthly with the traditional healers that I work with, and we co-designed the process to ensure that it's respectful of the healing that's taking place. And going back to that etiology piece too, so for a lot of Anishinaabe people, especially those who have traditional beliefs, it's a very stressful thing to talk about cancer, because part of our worldview is you're very careful with your words because your words have power. So to actually talk about cancer is thought to evoke cancer. So when we started this project, we had to ensure we actually went through ceremony that was guided by advisement of cultural coordinators, and we had knowledge holders involved to create that space so that we could open up and talk about it, right? It's not that people weren't interested in talking about it, but we needed to create the proper environment and context for them to do so. And so also developing and utilizing tools are great, but ensuring that those don't replace relationships and people. So tools can be helpful, but not having a checklist approach. And then also creating space for Indigenous and racialized people across the spectrum of research as well. So within the funding call, which is a partnership between GACD and the Canadian Institute of Health Research, there's actually, when you're working with Indigenous peoples, for example, there's requirements that you have lived experience or have so many years of work experience as a way to ensure or work towards more representation in regards to Indigenous peoples as well as racialized peoples, and thinking of gender as well, having representation. So maybe I will just leave it there. And so here's 4 kind of high-level points just for people to keep in their minds as we continue on in our conversation. Miigwech.
Thank you, Lana, for that insightful sort of opening, setting the scene for us for this session. We heard several high-level themes: structural issues, access. You spoke about localization. There was some themes surrounding power dynamics. items that we hope to peel a little bit more, deep dive a little later in our panel discussion. But before that, I would like to pass over to Izzy for her presentation on highlighting the GACD research network itself, specifically the Cancer Research Program, as an example of international collaborative efforts. Over to you, Izzy.
Great, thank you so much, Aruna, and thank you, Lana, as well, for your wonderful opening and scene setting there. So as Aruna mentioned, I'm going to speak a little bit about the GACD Research Network and what that means. And historically, I think it would be fair to say that projects funded under an agency or under the same umbrella may not formally be aware of each other, and it's not always the norm for them to actively engage with each other, even though they are funded to address a common theme. And the GACD has aimed to shift this through their approach to project teams after that funding is granted. And it might just be that some of these approaches that I'm about to talk about might spark an idea for you and your work. So GACD sits at the nexus of non-communicable diseases, including cancer, low and middle income settings, and vulnerable or underserved populations in high-income countries, and implementation research. And it's the first collaboration of major research funding agencies to address NCDs as an alliance. And together, the members of GACD represent 80% of global public funding for health research. And through this funding and the work of our fantastic project teams, our aim is to reduce the burden of NCDs in these populations by building the evidence base, informing national and international policies, and ultimately contribute to the Sustainable Development Goals under Section 3.4. So to just get into the detail a little bit, to date, 6 research programs have been funded, with the most recent grants being awarded in 2022 as part of our Cancer Research Program. And if you're quick at maths, in total, you'll see there are 133 projects there operating in 80 countries worldwide. And so far, so good, and perhaps so traditional. So this is typically where one might see silos start to appear, even within the common fields of implementation and NCDs, and also silos at that sub-level within each program or disease area. And this isn't a criticism on the field of how it's working or what is being done at the moment, just an observation on how things often end up, even with the best intentions. So GACD as an organisation and as a network aims to maximise the crosstalk between these different streams. So the research teams who are receiving funding as part of a GACD research programme form a community under the banner of the research network. And at the moment, that is more than 800 people across 70 countries, and this is open to anyone working or contributing to the project, from principal investigators to project managers, implementers, students. And this mimics the multidisciplinarity of implementation research itself and is inclusive from the outset. And if you look over here, we're looking forward to welcoming a few more soon, as we're due to announce newly funded projects through the Life Course research programme, and we have other funding opportunities coming up soon. So just to think a little bit more about the cancer research programme we've got here, and the 23 projects that we have in the cancer research programme operate in 39 countries across the world, and that's either countries of administration or predominantly countries of implementation. And we all know they have one thing in common: their focus on implementing cancer interventions. But beyond the obvious, the question is, do they have anything else in common that might bring them together? And the answer probably doesn't surprise you, but absolutely yes. So part of the GACD's remit is to identify those trends, those commonalities across apparently disparate and geographically diverse projects. And there is great scope there for transferable learning. But despite this variety, there are 9 separate project teams within this research program alone, all using the same framework, all using RE-AIM to evaluate their implementation strategies. So by doing this, by identifying these trends, these commonalities between diverse projects, it alleviates some of the burden for project teams on knowing where to start with collaborations and knowledge sharing. And what we create here is a ready-to-go set of commonalities to build on and advance that. And beyond identifying those trends and telling them about themselves, we try to further facilitate cross-project working and collaboration by the election of co-chairs, and you will recognize a couple of these faces already. And unfortunately, Andrew couldn't join us today. So the election of co-chairs is an important component of our work. As so far I've described helpful but ultimately top-down opportunities for connecting. And you can see here Aruna, Andrew and Lana, who were voted in by their peers to be the co-chairs of the cancer research program, and that is across all 23 projects. But rather than sitting above the rest of the program, Aruna, Andrew and Lana are more like key hubs embedded within this network of project teams, and they provide vision and direction from within the research program and lead on joint activities and publications, and this symposium is just one example of them doing that. And as Lana mentioned, GACD also brings project teams together physically through the annual scientific meeting. This is a closed event. It's exclusively for the researchers and implementing partners working on GACD projects past and present. And as a closed event, there is great scope for digging into the challenges and the opportunities presented through implementation research, to share findings, experiences, data, potentially pre-publication among the trusted collegiate group. We developed the program alongside our research network. We asked them what it is they want to hear about, who they want to hear from. And for example, here you can see delegates playing a game to prime them for some creative interaction later in the program. And here is a member delivering an update on a cross-project and cross-program working group. And we also have group activities within the program to help facilitate that networking and explore cross-cutting themes. And a key aspect of creating that collegiate and supportive environment for knowledge sharing is through interpersonal leveling. And one tool for this is removing the titles and post-nominals from name badges and delegate lists. This is perhaps not always noticed, but it's an underlying supportive factor. And it helps to validate and value all the ideas that are shared during an event, regardless of the traditional seniority level of whoever it was that proposed them. And here you can see some name badges from the event that Lana mentioned that happened in December, where professors, clinicians, early career investigators, and even lowly research managers such as me were all equally leveled by the use of their name and their institution only. So we hope to see through the efforts of GACD and its research network members is a bottom-up researcher-led approach to collaboration that's amplified through that top-down support. So with Lana's scene setting and these quick fire examples I've given to you from our research network in your mind, I'm delighted now to hand back to Aruna and to our guest panelists, and they're going to explore the benefits, the practicalities, and those wider considerations of collective action and independent action around implementing cancer, implementing evidence-based interventions for cancer. And answering that question Aruna posed at the beginning, is the whole greater than the sum of its parts? But more than that, do we have capacity to harness it? So over to you, Aruna.
Thank you, Izzy, for that overview of the GACD network, and Lana for setting the scene earlier. So to answer the questions on is the whole greater than sum of its parts, and do we have the capacity to actually harness it? We have with us today Ishu, John Black, and Lana, who will be joining us in today's panel discussion. I would just perhaps give the floor to Lana, John Black, and Ishu to perhaps, again, once more to briefly reintroduce themselves and the GACD projects that you are involved with, and perhaps just a brief overview of the project. Perhaps we can start off with Ishu. Ishu and I are involved in the Access Cancer Care, the ACCI project, and Ishu, perhaps you can talk a little bit more about the project that we're involved in.
Sure, Aruna, thank you. So as Aruna mentioned, the GACD project that we have on cancer is called Access Cancer Care India, ACCI. So what our project basically aims to do is that we would be designing and evaluating a multi-level strategy, which is both integrated as well as contextualized to the local health system. And the aim is that we want to really improve access to early detection and care continuum for the three most burdensome cancers in India, so oral, breast, and cervix. And the focus is that we will be working with the vulnerable population that is in the rural areas of India across 3 sites, 2 of which are in the southern part of India. So we have sites in Tamil Nadu, and we have a site in Kerala, and 1 site in the western part of India, which is in Rajasthan. So that is in brief about the GACD project that I am working on along with Aruna.
Thanks, Ishu. John Black, perhaps you would like to reintroduce yourself and some the work that you do with the GACD project.
Yes, so the project is Preventive. I've just put a URL in the chat. Preventive is an acronym for Prevention and Screening Innovation Towards Elimination of Cervical Cancer. We always have to come up with some sort of acronym, but it, the name is, I think, is indicative. This project is led by a team actually from the Netherlands at the University of Groningen and at Leiden, the Female Cancer Foundation. But the actual implementation happens in what you would say low-income countries. So in Uganda, in India, in Bangladesh, and in Slovakia, which is in Europe. The project has different components. So we go all the way from awareness creation. We're targeting women in rural communities where usually they have limited access to screening services. And we do awareness. We also are trying out cervical cancer screening using high-risk HPV DNA testing, which, of course, for example, in Uganda and in India and Bangladesh, it hasn't been the norm. They've been using visual inspection. But since 2021, WHO is calling for better screening methods, and HPV DNA is one of those. Of course, this is a new way of doing things, so we need to understand how to achieve that. Usually with VIA, the advantage is that you see the woman and then you screen her and you treat her, because if you let her go, for example, with a pap smear, she might never return. Where you have optimistic screening, and in this case, with HPV DNA, you lose that opportunity of see and treat. So we need to see how this works. Of course, it comes with some advantages. For example, self-sample collection or self-swab collection. So we're testing that, and it's, I should say, going fairly well in the spirit of sharing data that is not yet published, as Isa has just talked about. And then we're also testing other innovations, particularly using digital health components. For example, a simple electronic medical record system that runs on mobile phones, so that we can have data that can be used for research and for follow-up and for tracking. And we are also testing even more innovations, artificial intelligence, so that we can support the nurses at the front line who might not be able to tell if this lesion should be treated at the local clinic or be referred. So there's several of these work packages that are being conducted by different teams. We also have a health economics evaluation because we need to find that some evidence that this is feasible economically. And so there's all these different teams and the different work packages. Yeah, we've been running for about 2.5 years. We have a few, maybe less than a year left. But yeah, I've shared the link and you can find some more information there. Thank you.
Thank you, John Black. Even as you were speaking, I could already, Ishu and I are smiling because we see a lot of commonalities between our projects already. And I mean, we can speak about that soon, but before that, I'd like to invite Lana over. I mean, we heard a little bit about your project earlier, Lana, maybe a little bit more before we start discussing the questions that we've set for today. Over to you, Lana.
Yeah, as mentioned, so the project is the CUGH Nanandawegamig Minobamadazoin project. So CUGH Nanandawegamig is the name of a traditional healer from the area where we're doing the work, and it's also the name of the partner that we work with. So WINHAC or CUGH Nanandawegamig Health Access Center is our partner under the leadership of Serena Joseph. And Minobamadazoin, that refers to our ways of health and healing within an Indigenous context. So there's two main components to our project. One is actually documenting the experience and the outcomes of people who actually visit with a traditional healer. So very similar, like if you're seeing your NP or if you're seeing your doctor, you come to the clinic and instead you are seeing a traditional healer. So we're doing that in regards to cancer prevention. So another component of the work is developing a culturally based and locally driven theoretical framework for thinking about cancer prevention. Seeing the impacts in relation to the framework, and then also when clients come in, we're linking that to their health data as well. So we're doing that in a prevention context, but also in a treatment context for cancer. And then the second part of the research program is looking at training and supporting capacity for traditional healing related to cancer. So I guess the easiest way to explain it would be perhaps our own medical school where people over 4 years receive training from traditional healers. Does not mean at the end that they will become healers, but they will have relationships and they'll have that door open to continue that work in their learning, and they may have other roles as well. So it's really difficult. It's a lot of work to obtain all of the plant medicine for their traditional healing. So people learn about the plants, they learn how to harvest the plants. So they may be in a role to start supporting picking and preparing plants for traditional healers to use. So it's kind of a one-stop shopping, for a lack of a better word, in terms of the work of the healer. So this way, building more capacity so the healers can spend more time with clients versus having to actually pick and prepare some of those plants.
Thank you, Lana, for that introduction to your project. And with that, I'd just like to start the conversation off by asking the difficult questions. What do you feel are some of the major challenges that you faced in your respective projects, and that you feel that are often not the challenge that is spoken about when we actually discuss challenges in cancer research projects? Ishu, perhaps you'd like to get started with that.
Sure. So I think, Aruna, I will begin with some of the challenges that are not often documented, and those are administrative challenges. And this is because through our project, we are facing some of those challenges, but also the ways that we've been able to sort of mitigate them. So I'll probably focus on 3 different types of challenges that we've faced with our project on cancer. So one of the key challenges is ethics. And I think that is very important to consider while planning the project, while planning the timeline. For us, as I had explained earlier, we have 3 sites. So we required approval at all 3 sites, which takes time because each site environment is very different. Their ethics process is very different. The ethics forms are very different. What they need can be varying between different sites. Therefore, what I feel that it's really important that we need to build in some time while we are thinking about our project timelines and developing ethics applications. So the aim is that you are building in time for the submission cycles for each of the different sites that you might be working on. So therefore, it's very essential to keep a buffer. And I think that's one key learning that we've learned through our project. The second thing that I want to highlight is similar to that side. So once we've moved from a local site approval to a more national regulatory approval, this is something that we see, and we've seen in India where there is a national approval that comes from the government of India through their health ministry screening committee. And that is another whole level of application. So that is an application that is divided into multiple parts, need different components, and a whole different level of procedure that needs to be built in apart from what we would do in achieving local site applications. So the local site applications where we get ethics approval go into the national application, but there is scrutiny, and there is also, I would say, more perspective in terms of how, when there are grants like these that are between the funder, which is a foreign funder, and there are different regulations with respect to the country, we face that even national regulatory approvals can take a lot of time. So therefore, building in both sort of the ethics and the regulatory approvals is a must. And these can also become a little bit uncertain. So for example, in one of our national regulatory approval process where we have to get multiple different levels of approval, one approval got tied up because there was something happening in the background with the technological system. So we had to wait longer than the usual time to actually get approvals on that aspect for our application to move forward. So I would say those things, again, need to be built in. And finally, I would say that once you've got sort of the ethics approval and the regulatory approval, the third challenge, the main one that comes to picture, is that when you're trying and going to actually beginning implementation, the ethics approval are important, but you also need sort of the administrative approvals at the local level. So for instance, in our project, we are working in a district in each of the 3 states that I described to you. So district is basically a geographic or an administrative division within a city or a state. So we need approvals from the chief medical officers there, from the health leads there, to be able to actually start implementing projects. So what I would say, Aruna, that for us, I think these 3 key administrative challenges are very important. And I would say that if we can build a timeline to it while we are thinking of projects bidding or planning, I think that is very important to give that time to it so that we can have smooth implementation of the project.
Thanks, Ishu. I think that was most insightful. I'd like to just pass to John Black or Lana. Do you feel that those are some challenges that you have faced in your projects, or if there's anything that you feel that you want to add in terms of challenges that are often not discussed when it comes to cancer projects?
Yes, I can go first. Indeed, those are real issues that we face. Administrative clearance. We have a lot of, when you have many groups involved, you have the local and the, maybe even an international IRB or approval from a different site, and they might not be agreement. But I wanted to add something else that I think is another issue, which is the, I would say, siloed way of conducting research, and also the time that it takes for research to become publicly accessible. And the problem that I have with this, and I've experienced this in this very project, is that there is a lot of waste of the few resources by people repeating similar things that were already done by someone else. And the example I'm going to give is that the project that we're working on now involves a component of developing artificial intelligence. And I was already doing work around the same issue before I joined this project. But because of the time that it takes for doing research and publishing, and someone else writes a proposal to address the same problem, and they begin to deal with the same issue. Of course, here there's benefit that I ended up joining the group, and so we can already borrow even the not yet published insights and make the new project go quicker. But in many other instances, this doesn't happen, and you have a lot of duplication of things that have already happened. And I think some of the solutions that should be, of course, collaboration and meetings, and sharing at consortium meetings, that helps that people know what's going on, and maybe even having like a repository where ongoing research is posted, and we give as much detail as possible. Who is working on this project? What are they doing? What specific questions they're addressing? I think that helps. And if we could have something like that, maybe even the funding agencies can go there and they can decide what they should fund, as opposed to this top-down funding. We could have a more bottom-up approach where the issues have been realized from the field and they have been posted, and we can direct the funding mechanisms and the research questions that are being tackled from that perspective. So I think that's a very problematic issue. Of course, there's a few others, but I'll leave Lana to speak from her perspective.
Great. Yeah, I think just picking up on some things that have been said, definitely a tension between the community and what the community conceives of as ethical as well as accountability versus how that's actually rolled out at an institutional level. And I'll just give two quick examples. So one, when we're thinking about administration, one thing that is required when I actually submit as kind of backup or proof is to have formal agendas. And those just don't exist. And if I bring in a formal agenda, that's really not going to fly, because I'm not the one leading the process, right? So our projects and our meetings in certain contexts, when we're working with elders and traditional healers, are often more iterative. So that's one example. So we've had to do extra work to essentially create agendas to show evidence, but it's really not an effective means of accountability at all. And then even just some of those other processes, often we're doing things on the land. So what does insurance looks like for car rentals when you're not on designated roads, all of those sorts of things. So we've been able to flow a lot of our funds through to our community partners, especially when thinking about honorariums and these sorts of things. But that's still really problematic, because it's the university who benefits from the administrative fees as well, and not the direct community partner who's still doing a lot of administrative work. And then in regards to the research ethics, so for example, in Canada for First Nations, there's a framework for research called OCAP, which means that First Nations communities actually own, control, and have a right to access and possess their own data. So that's the framework that I try my best to work in, but it's really difficult to do it within the constraints of current research ethics board processes and other processes. So even the requirement to store data for a certain amount of time, it's always a negotiation, a conversation, because I can't commit to that because it's not my data at the end of the day to store. So those are just a couple of quick examples.
Just as you're speaking, it shows the diversity of the context that we all come from with our different projects. While we're speaking about challenges, I think it's also important to highlight some of the transferable learnings that we can share. Perhaps, is there any examples that you can share from your own respective projects that you can highlight? Issue from our Access Cancer Care project, we know there have been common tools that we've developed. for our projects within the different settings of GACD projects. Perhaps you'd like to highlight some of those transferable learnings. Ishu, over to you.
Sure, Aruna. So as Aruna mentioned, we have 2 cancer projects that have been funded by GACD in India. So one is our project, which is Access Cancer Care India that I have told you about. And the other is the We Can project, which is Women Empowerment Cancer Awareness Nexus. So a little bit of what We Can is trying to do, and then I'll tie it up with what we are trying to do. So the We Can project is, the aim of the project is to reduce cervical cancer among, again, rural low-income women. And this is in both rural and urban neighborhoods. And this is happening across 8 states of India. And what they are doing is they're encouraging self-sampling for HPV. So what I would say is that there are some commonalities that stand between the We Can project and the Access Cancer Care India. So what, as a baseline, both projects want to do is to understand what is the knowledge and awareness about cancer among general population, as well as those among cancer survivors, as well as understanding the barriers and also assessing what kind of barriers are there for access to early detection and treatment. So the difference that I can point out is that we are looking at 3 different types of cancers, as I told you, so oral, breast, and cervix. And the We Can project is focusing on only cervix. So what we are trying to do is that when the tools are being developed with these common threads in mind, as I've explained it to you, we would be sharing these tools between projects so that they can be adapted to each other's needs. And then this would be also sort of sharing and learning aspect, which we can transfer while we are working on the project. And I think it will also be very useful once we've been able to deploy these tools, be able to gather data to see what we can learn collectively between the 2 projects with similar themes that would come out with regards to knowledge, awareness, as well as the barriers as well. So this is sort of one example concrete that we are doing with regards to transferable learning with our project.
Thanks, Ishu. John Black, there's actually a question for you in the chat. Joylene has asked, to what extent does publication of research protocols help avoid duplication? And in your case, did you already have a protocol published for your AI project? Do you want to take that on?
Yes, thanks, Joylene. That's, I think, a very good question, and I would say a suggestion on the way forward to this problem. There's of course a limitation because publishing protocols is really also like scientific publication that can take a lot of time going back and forth with reviewers, and sometimes you have projects that don't even have the more implementation. So, for example, we did a project before where the funder was most interested in implementation and less on the publication. The current project that we're doing, the Preventive project, the protocol has been submitted. I think it has actually been published. So that should indeed help avoid duplication. The question, of course, here is, do people look at this protocol, repositories or publications to decide if they should undertake a similar project or not? I think some people do, some people don't. The funding agencies should be looking there to say, if I'm going to start a project in Uganda, let me see what's going on there. The other thing, of course, that you've noticed is that if you go to, Prospero, wherever the protocols are put, many of them are not updated, and it really needs some sort of deliberate, intentional collection of information around, ongoing projects and have those updated. But yes, I think that should address Jolene's question. I wanted also to just mention some sort of the learnings that on that topic and highlight the approach that we are taking in Uganda, also in India and Bangladesh, of using community health workers as the foot soldiers, literally, in cancer control. In Uganda, for example, we've used a lot of, we call them the village health teams, VHTs, and they have been used for the usual issues, usually maternal and child health issues, the traditional priority issues, HIV, AIDS, malaria, and they help bring test kits to the homes. They do awareness. They assist when there's a child who is running a fever or something like that. And we have been able to piggyback on this established mechanism because it comes with trust. The community health workers are known by the communities. They're trusted. They are on the same level as opposed to how the community will look at a researcher parachuting in from a different part of the country or even a different country altogether. And this has shown really a lot of value in terms of getting adherence and getting uptake, and even increasing the efficiency, because the researchers or implementers cannot possibly reach out to all the communities in their homes. And I think that is something that can be learned from one project to another and from one country to another, to especially where you have a lot of challenges with the healthcare system. So I thought that should be highlighted, and also say thank you to the community health workers if they are in the meeting. Over.
Thanks, John Black. I would like to perhaps comment on Joylene's question earlier as well. In terms of publication of research protocols, even that takes time. So what has helped, for example, in our project, for what issue highlighted earlier, was that the networking events that GACD had helped organize helped highlight some of the commonalities between the project. And even before the publication of our respective research protocols, we were able to basically synergize and work together to develop the tools, and that helped. So like I said, even publication of research tool takes time, and in that duration, there could already be some duplication of effort. So the networking events definitely help. I'm conscious of time. I would like to ask one last question, and perhaps this can go to Lana. Lana, what you spoke about the indigenous population. So this is a question to you. What equity issues are drawn into open when project teams work together? How does that impact our ability to basically harness the full potential of collaborations? And what can actually, it's a lot of questions, but I'm going to try to sort of streamline it. What can be done to ensure underrepresented groups have a voice in networking cancer research? Over to you, Lana.
Mm-hmm. Yeah, so I think that practice of having Indigenous peoples involved through every stage of the project, and even in thinking about some of these dissemination events, I know we had, even for the scientific meeting, we had ensured that at least one of our spots was actually for someone from community to be able to go and engage. And that was kind of something that we knew was important, but as the project went on, the importance of actually having community or peer-led dissemination and knowledge translation, both to support capacity within community, but also to actually support that message being received in different contexts. And I'll give one quick example. So one thing I do a report back to all of the elders or the elderly people who are considered knowledge holders in the area that I work with in Northern Ontario. And it just didn't seem right. It didn't seem to reflect the nature of the project, which was so collaborative and community driven. And it didn't go bad, but it didn't go great in terms of trying to have that conversation and share that information. So we developed a elders advisory group, and now I work collaboratively with them, and they set the scene when we do presentations, and then I actually do my sharing then. And what they really appreciated about is it also gives a check-in, so they know if I'm actually hearing them correctly. So I think that's maybe one of the important pieces too of always being critical and conscientious of some underlying assumptions about the flow of knowledge and how that works.
Thank you so much, Lana. I'm looking at the time, it's 4:15. I think we've come to the end of our session. I know we had a lot of things to talk about, but perhaps I can summarize some of your words and of our colleague, Willie Pommet, who couldn't join us in today's session, and from Dr. Kassab's opening remarks earlier. He spoke a little bit about dedicated and proper allocation of funding support, and I think that's something that we all agree with. So as a call of action from the GACD network, we believe that joint strategic planning, I think that's something that we spoke about, and prioritization of leadership needs and actual priorities of researchers based either in the low middle income countries as well as disadvantaged groups would be hugely beneficial. We spoke a little bit about, and I think there are some questions regarding conferences and intentional discussions in the chat, but I'm sorry we couldn't address that. But we feel that that should no longer be a barrier for networking events or generating new collaborations or to strengthen existing ones. It would be wonderful to see more joint appointments or rotational schemes that promote shared experiences and expertise between the different groups and the different consortiums, whether it's researchers based in high-income countries or even low-income countries. With that, I would like to thank you for attending today's scientific session, and it was a pleasure to talk to all of you today. Over to you, Mishka.
Thank you very much, Aruna, and thank you to the GACD team for a really incredible session, very thought-provoking and inspiring. And also thank you very much for your willingness to share more information after today's meeting and sharing the links and all of the contacts in the chat. So as many of you here may be aware, we had an open call for scientific sessions for the first time for this year's ASGCR. And this was the session that you just heard was selected. And we're most grateful to have had the opportunity to work with the GACD team this year. So thank you again. And now it's time to again join the live interactive Meet the Abstract Authors poster session. We hope you will have a chance to catch up with the authors you started talking with yesterday and start new discussions with others. So for those who were not with us yesterday, please note that the Meet the Abstract Authors session, takes place on Gather, the platform, and the links are being placed in the chat. So you can access the Gather link in the chat. And you can also scan this QR code that you see here on the screen. And that gives you access to the Gather guide and the poster listing. And you can also find them within the Gather platform by going to the materials stations. And then the posters do have numbers listed on them, and you can find them that way. And you can navigate through Gather and ask for assistance to look for certain posters. We will be closing the Zoom link during the poster session. So you will return here at 11:15 Eastern time in the US, and then you can calculate your local time zones. We will be welcoming the Rachel Perline Award presentation and keynote address at that time. So as a reminder, we will be closing the Zoom link, so you can leave Zoom and go to Gather. I will put my email in the chat. You can email me during that time if you need a reminder of the Zoom link. It's the same Zoom link you've had for all 3 days. We will reopen the Zoom link around 11 Eastern time to get ready for the Perline Award presentation and the keynote address. We will also make an announcement within Gather when it's time to return to Zoom. So please enjoy your time meeting the authors, and we will see you back here soon. Thank you, everyone.
Franklin Wong, who is going to introduce the Rachel Perline Award, as well as an honorarium that we have of the award, and then we'll introduce our 2023 Perline awardee, Dr. Yinling Wu. So now, Franklin, please take it away.
Thanks very much. Good morning, everyone. My name is Franklin Huang, and I'm an associate professor of medicine at the University of California, San Francisco, and the co-founder of the nonprofit organization Global Oncology. This morning, it is my distinct honor to present the 2023 Rachel Perline Global Cancer Award to Dr. Yinling Wu. This morning, I would also like to begin by recognizing the Perline family, Don, Rachel's father, and Sarah, Rachel's beloved sister, who are joining us today as well. Rachel was incredibly close to her father and sister, and we deeply appreciate the support of this award. Rachel and I grew up together in St. Louis, Missouri, and we were close friends throughout life, sharing a love of our hometown, medicine, and Cardinals baseball. She encountered loss relatively early in her life when her mother died from breast cancer when Rachel was only 13 years old. She graduated from Brown University, went to Tulane for medical school, where she also received her MPH, and then NYU for internal medicine residency. She then came to UCSF for oncology fellowship, during which time she was diagnosed with and ultimately would die from gastric cancer. Her time at UCSF was marked by incredible clinical care of her patients and recognition by her colleagues, her fellows, and the faculty. Our careers closely paralleled each other, and we would often talk about how to fit together these passions of global health, oncology, and basic research. She was passionate about global health and caring for the less fortunate. And she was always an intrepid and adventurous traveler, working in China and learning Mandarin. And yet she was entirely grounded in her upbringing, in her roots, in her friendships and family. The only person I knew who would call her friends on their birthday without fail. She believed that caring for others was a privilege, and at UCSF, her presence and absence still reverberate to this day. Rachel, facing the adversity of her illness, was incomparably Rachel, incredibly positive and spirited. She wanted to let everyone in her life know how much they meant to her. It's best represented in her own words and in her smile. There's a video of her final message online on YouTube, and I encourage you all to watch it. It embodies so much of her spirit. This award was established in Rachel's memory, and I cannot think of a better way to honor her memory today than to present this year's 2023 Rachel Perline Global Cancer Award to Dr. Yinling Wu. Dr. Wu is being honored for her commitment and effort towards reducing inequities in cancer care and making cancer screening accessible to all in geographic regions and strata of society. This year, we would like to make a special mention to one of the 14 nominees for the Perline Award. We received a posthumous nomination for Dr. Bongani Kaimila, who passed away, unfortunately, in a fatal car accident in Malawi at the end of 2022. Although this year's awardee, Professor Yinling Wu, agreed that there would be in the spirit of the award to honor the memory of Dr. Kaimila for his contributions. Dr. Kaimila was an outstanding young researcher devoted to the study of esophageal cancer in his home country of Malawi, committing his career to treating and researching esophageal cancers, of which Malawi has the highest rates in the world. He grew up in Malawi and received his clinical training at the University of Malawi. He then obtained a Master's of Medical Science with a focus on global health and epidemiology at the University of Hokkaido. In 2014, he joined the University of North Carolina project in Lilongwe, which became the research focus as he enrolled in a PhD program at the University of Blantyre. Throughout the years, Dr. Bongani's expertise, commitment, and enthusiasm have ensured sustained collaboration with institutes such as the USNCI and the International Agency for Research on Cancer, and the cancer research and control community will dearly miss him. Now to this year's awardee. Dr. Yinling Wu is a professor of obstetrics and gynecology at the University of Malaya and a consultant gynecologic oncologist at the University of Malaya Medical Center, Malaysia. She has extensive clinical and research experience that ranges from prevention to treatment of cervical cancer and hereditary familial gynecologic cancers. She completed her specialist and subspecialty training in gynecologic oncology in the UK and was conferred her PhD by Cambridge University for her postdoctoral research on HPV immunobiology. Dr. Wu left Malaysia as a teenager and spent 21 years of her education and professional training abroad. And in 2010, she returned to Malaysia as a clinician scientist, focusing on service development and research programs with an emphasis on gynecologic cancers. As a translational scientist, she has worked tirelessly to making this knowledge more accessible and applicable to the broader population through her advisory role on policy development nationally and internationally. She also dedicates her time to working closely with other academic institutions, NGOs, and other industries to educate, inform, and advise on matters pertaining to control of HPV-associated diseases. She is a founder of the Rose Foundation, a nonprofit organization dedicated to making cervical cancer prevention accessible and affordable to the underprivileged, and she is deeply committed to making cervical cancer a rare disease in our lifetime. Among her outstanding achievements, she developed and implemented Program ROSE, an innovative cervical cancer screening program incorporating HPV self-sampling. And in her presentation, we will hear more about this program and the other initiatives that have marked her outstanding career. Dr. Wu, congratulations on your award, and we look forward to your keynote address today.
Thank you. So without a further ado, if you allow me to share my slides, I would thank you very much. Are you able to see my slides?
Yes.
Okay, so I'd like to thank the ASGCR committee for the honor of delivering this lecture. I want to thank my family, friends, and Malaysians who are staying up at this hour to join me for this talk. When I first found out about Rachel, I Googled and I tried to discover as much as I can about her. And I watched a video that Franklin talked about, and her life really moved me and she touched me in many ways. I could relate to Rachel in so many ways in terms of how she has a bigger global picture for health, but she also looks after patients on a one-to-one basis. I heard a story of her drinking barium enema just to prove to the patient that it is safe. And I think these are the doctors that we hope that the future generations will have their heart for patients, both globally as an individual. For me, it's a real honor to be delivering this lecture. Donald, Sarah, I hope it captures the spirit of Rachel. I thought long and hard about what I was going to say in 20 minutes. How do you capture so much in such a short period of time? So I'm just going to keep it simple and take the advice of James Haggerty, who is, by the way, an obituary writer for the Wall Street Journal. He says the best stories show not just what I've done, but to say why and how. So as you've heard, I've spent a large part of my life overseas and abroad. My undergraduate studies was in Trinity College, Dublin, and my postgraduate training was in the UK. My mentors knew I've always wanted to come back to Malaysia. And despite not having ever visited Malaysia, they prepared me, they skilled me, and they really gave me what I needed to return to Malaysia. And I thank them for that. So this year marks the 13th year of me working in Malaysia. And in a typical Malaysian way, many would ask me, what do you do? Do you teach? Do you see patients? Do you do research? You do community work? What do you do? And to that, I answer a bit of everything. And that's given me a perspective of the problems that we are to solve in my homeland. So why? And that's the simplest of all. As I transitioned from being a child to a mother, I observed, I experienced, I've come to appreciate the central role of a woman in a family. I'm not saying that the men are not important. My grandmother, who you see here, brought up 8 children pretty much single-handedly. And my mom, well, she's a super mom, and as all moms are. Over the last couple of years, mom has battled cancer courageously, and fortunately, she's now well. This really brought it close to home how cancer has such a major impact on individuals and families. For me, this personal experience has reinforced why I do what I do. And so when I look after patients and when I hear their stories, they're not different from me. Their hopes, their fears are similar to women of generations in the past and generations to come. And so the real driver, the why of what I do is to keep women healthy. Malaysia is my home. It has a population of about 33 million, and we have a multicultural, multi-ethnic, and multi-religious society. We are a Commonwealth country that received our independence in 1957. But more than that, for those of you who have visited, you can agree with me that Malaysians are warm. Our food is great, the durian being controversial, and our country is really worth visiting. But this is my Malaysia, a Malaysia that's unlike any other, full of promise and fragility. Its history, culture, and religious diversity makes it rich, compelling, and a surprising land. It is in this Malaysia Program Rose was born. Program Rose has now become synonymous to empowering women towards cervical cancer elimination. For those who don't know what Program Rose is, it really is a comprehensive cervical screening program that reaches out to women in the community so that they can perform their own screening test with a swab, not too different from a COVID test, and then communicating with them through their mobile phones, linking them to care should they have an abnormal test, so that the process of screening is complete without even necessarily stepping into a healthcare facility or a hospital. Now, this means a lot to women where going to a hospital is a fearful experience or will cost them money. So Program Rose started in 2007 as a pilot project, a research project undertaken in UM between University Malaya and VCS. When the project ended, it seemed that we couldn't just stop there because it was such an acceptable intervention for women. And that's when Program Rose was started. The foundation was started to deliver the program to the underserved population. And subsequently to date, we've screened more than 23,000 women, educated hundreds of thousands of women, and we continue to reach out to women who are under-screened. Why Rose? As a gynecological oncologist, it's one of the most common cancers that I encounter at the hospital. It's hard-hitting because most of these women are around my age with families. And this really shouldn't happen because, ladies and gentlemen, this is the first cancer in the history of humankind that can be eliminated in our lifetime. We have the tools today and we need to use them. And it's a matter of how we use them in our different environment. We have vaccines that work where 90% of our girls should be vaccinated. We need to reach our women and screen at least 70% of them. And if they're screened abnormal, 90% of them should be directed to the appropriate care. So how do we get there? And this is where the how comes in. How do we work towards elimination of cervical cancer in Malaysia? Fortunately, when I returned to Malaysia in 2010, the government had made tremendous effort to initiate a national HPV vaccination program that was fully funded, free for all 13-year-old school-going children. And on an annual basis, more than 80% of girls were vaccinated. Naturally, you would ask, what is the impact of this vaccination program? And so, through the sheer determination of one of our PhD students, we've demonstrated very recently that after 10 years of vaccination, the infection rates of HPV in the population among those who have been vaccinated has reduced by more than 90%. This means that it would translate to women having a significant reduction of the risk of cancer. But what about those who've not benefited from the vaccine? Adult women like myself. Women were just not getting screened effectively. Despite it being free since 1969, less than 20% of women would have had their screening tests done regularly. And this problem is not unique in Malaysia. it's a common situation in lower middle income countries where 80% of the burden of cervical cancer lies. And this is when the innovation of Rose came in. I want to put in a disclaimer here. I'm not a trained public health doctor. Neither am I an implementation scientist. In 2017, I didn't even know the word implementation science. I used the principles of design thinking, purely trying to put together a program that empathized with the users, the healthcare professionals, and the patients, define what the problems were, come up with a solution, and to prototype and test. As you can imagine, such an initiative would require multidisciplinary effort, skills, and thinking. It wasn't just a test we wanted. I wanted a solution that would ensure that women will complete their screening process and get treated if necessary. Didn't want to come up with a design that has really perfect protocols, because we know protocols and patients may not necessarily align. We can come up with things that do not really wasn't convenient to our users, and I was very aware of that, and hence the solution needed to be friendly to our women. Program Rose came about during the time where HPV testing was shown to be superior to the conventional Pap smear. Using a swab such as this, women were able to take their own samples without requiring an uncomfortable pelvic examination. And as you can imagine, this is a real paradigm shift of how we've always done screening. And so we needed a significant amount of effort to change the practice and to come up with something that is so innovative, new, but evidence-based. How do I convince our collaborators or individuals to join me? The narrative behind the cervical cancer elimination is a compelling story. But as I quote Dr. Bayer, the creator of ER, one of my favorite shows, most people are not data-driven. They're driven by stories. Only then can we provide them with data, giving them context, giving them evidence. They need to be moved by the story first. And this was something I learned because I had to speak to financiers, lawyers, project managers, talk about business sheets. I had to use language to get buy-in from telcos and media, really learning how to deliver the cervical cancer elimination story effectively. If you look at the bottom two pictures, you can see at the very start, I even had my mom had to edit my speeches, edit some of the press releases that we were making. And the kids were also quite involved in the project. Ethan doesn't know this, but I kept this image because one day I was on the phone having a chat with someone about raising funds for Project Rose. And at the end of the conversation, he shows me his drawing book. Mom, I know how you can raise funds. This is the plan. You make t-shirts, you advertise, you sell, and perhaps you can set up a stall in the Pasar Malam, which is the night market. So the program was designed with the patient in mind, understanding the steps in which patients have to take from one health clinic to the hospital and where the cracks were in the health system to make sure that we make that smooth for each individual woman. The entire program is conceptualized and tailored based on local needs. Even the name of the project was thought through on the back of my rough paper block. So we need to identify local barriers and come up with local solutions. In designing this problem, it is important that we do not helicopter a solution from another environment into the local environment. In his book, Turning the World Upside Down, I found a few important observations made by Sir Nigel Crisp. We may have all the knowledge and scientific data as healthcare professionals and academics, but we may not be able to get patients to do what they need to improve their own health. So if we were to apply, we must be capable of dealing with the uncertainties of trust, belief, and perception, which is increasingly becoming a major barrier. Remember, people, patients, and society versus scientific knowledge and systems. So even as we prototyped and developed the interface for the mobile phone, we had to make sure that it was usable and simple. And that was how Program Rose came about in a few minutes. After we came up with the program, we also had a few little other steps to take. We developed a laboratory so that the highest standards of HPV testing can be provided to women at the most cost-effective manner. We collaborated with our friends in the then BCS, which is now known as ACPCC, to really accelerate the capacity to test and to use the expertise. We have to create a foundation in order to execute the program. This is the foundation whereby we could solicit funds so that it could be delivered and given back to the women effectively. Even the sign here was donated by an individual. It really was, Rose really was a story of building the trust and relationships with people around us, with stakeholders who believed and still believe in the vision of making cervical cancer a rare disease in Malaysia. So Malaysian women you can find are very open to the Rose test. They find it acceptable. Self-swabs can reach, and we have reached, a previously underscreened or even unscreened population. And really through our community programs, we've seen many women come in on wheelchairs and have screened themselves for the very first time. We have empowered our frontliners, particularly during the COVID pandemic, to look after themselves, such as the police force and the army. So to date, Program Rose has achieved quite a lot. We've trained many volunteers to teach and to screen their own communities. We've engaged with more than 90 healthcare professionals, and we still have lots of room to grow. So just to show you a glimpse of what we've done, even in the first year. Ultimately, this is what matters, women being saved from cervical cancer. And these are just a handful of those who have really benefited from the program. We discovered cervical cancer early, and they are now survivors and not victims of the disease. I cannot end this talk with just talking about cervical cancer. As a gynecological oncologist, one of the other cancers with many unmet needs is the screening and treatment of ovarian cancer. Staying to the theme of collaborative partnerships, I want to share two Malaysian-centric efforts that I have been part of. One of the major gaps about 10 years ago when I came back to Malaysia was the lack of genetic counselors. Part of the care provided for women with ovarian cancer is to discuss the options of genetic counseling to identify any risk of hereditary ovarian cancer. So being part of one of the largest collaborative studies led by Cancer Research Malaysia, we determined whether doctors like myself could be involved in the counseling of women on genetic testing. Was there more psychological impact when the counseling was done by a doctor as opposed to counselor? Really, the findings were very encouraging. This has really been a game changer because my colleagues and I are now able to talk to women, to talk to our patients about genetic counseling as part of their care without causing an increase in psychosocial impact. And more recently, in a very unique effort between patients and their physicians, between my patients and myself, we've joined the Every Woman Study Lower and Middle Income Edition, which involves 24 lower middle income countries, 31 languages, just to establish what the local needs of women with ovarian cancer are and to advocate for them. And this really is a unique study in the sense that patients and doctors are working together for the same cause. And in this initiative, I want to share one story with you in the sense that one of our survivors, the late Selina Benjamin, established the first ovarian cancer support group in Malaysia. Such initiatives, although starting off as a research program, no matter how small they are, if they are able to enrich a patient's life, it is really worth the effort. So as I end, I want to make a few reflections of what we have achieved so far as a country and as a team. I think I've learned that we need to be courageous in developing culturally appropriate medical interventions. We need collective action. And by that, we need to engage with each other through various sectors and through education, financial sectors, and even the media. We need to connect with stories. But most of all, we need to develop and implement patient-centered interventions for patients and their families. We need to teach our next generation of healthcare professionals empathy in care and research. I believe if that's the core of how we drive research, we will actually be very productive in what we do. And countries like Malaysia, this is where I want to make a plea for our country and other lower and middle income countries. We must be able to train, to retain, and to provide a healthcare workforce that will keep our nation healthy. So for those of you who are Malaysians and who are out there not back home, I ask that you consider coming back to help develop this health force. So these are the images of hope and health that I capture when I'm out in the community. Look at the little fella's hat. It says, "I can go anywhere," in his mother's arms. So let's ensure that we keep our women healthy for the future generations, for they are the fabric of societies and of the nation. So I thank you once again for this award and for the opportunity to share. And lastly, a tribute to the courageous women who have taught me and shared so much with me. And I'd like to echo the words of So Hui. She says, this is not the time to be sad and to lament about our fate, but to fight the disease the best we can. And So Hui, I want to reassure you that we are fighting the best we can. Thank you very much.
Thank you, Prof. Wu. And to me personally, Yinling, and I'm going to apologize, I've had tears in my eyes through the whole talk. So let me try to regain my composure and just say I've known Yinling since 2011 when she welcomed me to her home country as a guest, and has been an amazing inspiration to me. I remember the day she called me up on the phone and said, Patty, I'm taking a sabbatical. I can't watch another woman die on my table of something that we can prevent. And that was the start of her talking to me about design thinking and about what she was going to do. And it has been so impressive and so amazing. And I am so touched and honored to have her here sharing this work with all of you. I believe at the Center for Global Health, we should give Yinling an honorary public health degree, because if there was a public health scientist in the world that I've ever known, I think it is Yinling Wu. And I think this has been such an inspiration to all of us, Yinling. We really appreciate your sharing your stories with us. I think they resonate with everybody who's in this symposium, and you're such a tribute to Rachel's work as well. And so I hope her family also, I can see in the chat that they have really been impressed by your carrying on the tradition of, clinician scientists who really care and go out of their way. You and your wonderful team as well, many of whom I've met, and the ability that you guys have had to keep this going through so many obstacles is truly amazing. So I really thank you for that, Yinling. I think that we don't have time for questions today, but I am sure that Yinling would be very happy for anybody to contact her with for more information. And I know that Supe Kuf from the program Rose has put a link in the chat, and that can tell you a lot about program Rose. There are a lot of things available on the web. And Yinling, I just once again want to thank you so much for this really impressive work, such well-deserved honor that we're happy to bestow on you from NCI.
Thank you very much, Patty. Thank you. Nice meeting you, Donald.
Okay, and with that wonderful end to what has been an absolutely fantastic 11th Annual Symposium on Global Cancer Research, we at CUGH really care a lot about this meeting. We're so happy that we're able to virtually bring so many people together. We hope that we can keep growing it. We obviously couldn't do this without so many dedicated sponsors that you can see on this slide. This is truly, just in keeping with Yinling's talk, this takes a community, and there are a lot of communities that we're working with and trying to do what I heard earlier today, which is to make this a global kind of effort. And I hope that this meeting is really helping to do that. Of course, this particular agenda would not have been possible without the amazing work of our 2023 Scientific Steering Committee, who you see listed here. I think what you'll find is they did such a great job to line up some super interesting talks and really focusing on implementation research, which goes so nicely into what was just presented with Program Rose, which was a true implementation project. And I think I'll just echo that you don't have to be an implementation scientist per se to do fantastic implementation work. This is a lot of common sense, hard work, and dedication. And I think that what we can all do is to take, as we were listening earlier today, those lessons learned that could be translated to help other people and start connecting each other to do the kinds of amazing work that we've seen all throughout the conference and the symposium this week. I'd also like to thank our scientific abstract reviewers. We had many abstracts. This takes a lot of effort and work, and so we really appreciate all that went into that and making sure that we had the best possible science to share. And finally, to thank our speakers and panelists. I think that we had, some great first day of early career scientist investigator meetings with some really interesting panel discussions and breakout sessions around mentorship. And I think that this is, again, where we can start to really participate and mentor each other and start to get some, disseminated networks that we can connect together more often than we actually are able to do even through fantastic symposia like the ASGCR. We had two fantastic sessions yesterday focused on global implementation sciences. We had two Meet the Author poster sessions and a flash toss session highlighting some of the abstracts that were presented in the poster session. And then finally, we ended today again with just such a fantastic example of what clinical and community research can lead to in terms of really saving people's lives on the ground and translating the tools that we've all worked so hard as cancer researchers to develop and actually bringing them to realization and to the people who need them. We had 50 speakers, panelists, and facilitators and note takers representing 28 institutions around 20 countries. So this is truly a global effort, and I really cannot thank all of the participants enough. And so with that, I would like to again just close to say thanks again, particularly to our colleagues in Malaysia and other places where this is getting quite late in the day for you. But our ability to join in these kinds of venues is so inspiring, I think, to all of us, and it really gives us, that critical energy to move to the next step, because we all know that global research can be challenging, but you can also see how incredibly rewarding it is. What I'd like to do in closing is just to ask you if you could please take the time to fill out a 10-minute anonymous survey. It can help us to evaluate the symposium and to improve it in the future. The link's in the chat, and you can also use this QR code to access the survey. And I think with that, I will be very happy to be the one that gets to close what was just a wonderful 3 days. It was so nice being with you all, and let's work together to make this even better every year. Your contributions are essential. And again, final thanks to Dr. Yinling Wu for a just tremendous example of what we can do together to actually reduce cancer morbidity and mortality across the world. Thank you.